everyone, it's Doctor in the house and you are welcome. My name is Chris Kata. If you're joining us for the first time, this is the show I like to call the consultation before the main consultation. And the main consultation is when you get to the hospital. So on this show, we get to talk about everything about your health. And you get to know new things, you get to know how to manage whatever you're going through, and you get to also take care of yourself and appreciate the life that you actually have. Now, we are going to be talking about something a lot of people have overlooked, and it's actually important in maternal health, and it affects so many women. And like I said, it's often overlooked until complications arise. And the doctor in the house with us today is Dr. Kelvin Owusu, who's a wellness consultant at the Violet Medical Center. And today it's all about pregnancy and diabetes. Hi, Doc.
Hello, Chris.
How are you?
Very well.
Doc, are you ready?
Oh, yeah, I am.
Okay.
I am.
So let's get straight into it. You explained what diabetes was last year. I said last year. You know what I was thinking about? I was thinking about the events that we met last year. So you explained what diabetes was last week. And today it's diabetes in
women.
Pregnancy.
In pregnancy, yes.
Yeah. So tell us about diabetes in pregnancy, because I've heard about one that comes during pregnancy before, but just tell us about it.
Well, I mean, so diabetes, as we said last week, I mean, it's where there's a challenge with metabolism of sugar or glucose. And so the levels begin to rise in the blood. And it basically has to do with insulin. You know, so I mentioned that there's type 1 diabetes where the body is not producing enough insulin, sometimes no insulin at all. And so those people, they need insulin injections so that they can metabolize their sugar.
Right.
Then there's the type 2 diabetes where your body is producing insulin. In fact, sometimes your body is producing a lot more insulin than needed, but the insulin is not being effective in pushing the sugar out of the blood into the muscles where it's needed, you know. Now, there is a type 3 diabetes, which some people have said is a subset of type 2, you know, and that is where we talk about the gestational diabetes.
Oh,
where, yes, so type 3 diabetes is also known as gestational diabetes. It is, in terms of how it presents, it's similar to the type 2, because the body sometimes is producing a lot more insulin than needed, right? But then it's just not able to overcome the challenge, the insulin resistance, and so the sugar stays in the blood. But when we say diabetes in pregnancy, we need to explain it a little bit further. Yeah. You know, because you can have diabetes, pre-existing diabetes, and then you became pregnant. It's still considered diabetes in pregnancy.
So you can get pregnant when you have diabetes?
Yes, you can. Okay. You can get pregnant whilst you have diabetes.
Right.
I mean, we'll talk about it in a bit more details, but you can also develop new diabetes. You were not diabetic before, then you got pregnant, and then now you are diagnosed as diabetic. So that is what we call the gestational diabetes.
So we say it's the pregnancy that caused the...
Well, yes, it's as a result of the pregnancy, you know.
So is the pregnancy too sugary or blocking the insulin?
Well, you think about it this way. You know, when you are pregnant, you know, you are growing another human being inside your body.
Right.
And so your sugar requirement is higher because you are not only feeding yourself, you know. So the body mechanisms try to make more sugar available so that the baby can also, you know, enjoy some of the goodies, you know. When this mechanism doesn't go as it's supposed to go, then you tend to develop gestational diabetes. That is assuming you didn't have diabetes before. Now, the reason why it's important to understand whether it's a pre-existing diabetes or gestational diabetes is because even though they are all diabetes, they have different, different effects on the pregnancy, on the mother and the baby. You understand? And so the management may be the same, but we need to understand which diabetes we are dealing with because the outcomes might differ significantly. So, for instance, if a woman was...
So that's why it's always important to check.
Well, you know, pregnancy is actually one of those things that you need to prepare for. Unfortunately, many people do not prepare for pregnancy. They just get pregnant. You understand? There actually is a part of medicine which talks about prenatal care, which every woman needs to actually go through before they become pregnant, you know.
Oh, before they become pregnant?
Yes, you need to actually have a checkup before you become pregnant under ideal situation. But I don't know how many women have had a prenatal checkup. I mean, hey, they just get pregnant and we all say
congratulations. Because the Lord did it for us.
Yes, the Lord is good all the time. So, so many women may not even be aware that they are diabetic. The first time they discover that they have diabetes is when they actually become pregnant. You know, that presents a challenge, you know, because then you can't tell was it a pre-existing diabetes or is it a gestational diabetes? So it makes it a bit challenge. But the classic thing about gestational diabetes is that when the pregnancy ends, the diabetes also ends. It might sound like good news, but guess what? Up to 50% or more of women who had gestational diabetes will end up developing type 2 diabetes later on in life. So pregnancy is kind of like a window to your future. So if you develop hypertension when you are pregnant, there's a possibility that you develop hypertension later in life. If you develop diabetes when you are pregnant, even though the diabetes might disappear when the baby is delivered, you might develop diabetes later in life. So it tells you what's going to happen so that you can start preparing, or try and start preventing some of these things, you see. So pregnancy is a good thing. It shows you your future, kind of.
Hey. So what risk factors does women with, you know, pregnant women actually with gestational diabetes face? So,
okay, so in terms of how do I put it? What will make one woman more likely to develop gestational diabetes? Okay. You know, it starts with the age of the mother. You know, so if your first pregnancy is delayed, you know, mid-30s into your 40s, your risk of developing... Why are you making faces at me? There's a risk of developing gestational diabetes, you know. So in that regard, the earlier you give birth, the better for you. So
hey, you know, a lot of things happen with our age.
Yes, you know, and indeed, that's part of the reason why we are seeing a lot more of some of these things nowadays than previously, because now a lot more of our women are going into careers. They are furthering their education. So the starting family is getting more and more delayed. You know, so we are beginning to see a bit more of these in our setting than it used to be previously. So yes, maternal age at first pregnancy is a very important risk factor.
First pregnancy.
First pregnancy. Well, I mean, all pregnancies, but most of the time it's the first pregnancy. If your first pregnancy is late 30s into your 40s, you tend to have a bit more issues than somebody who has been pregnant before. You know. Then if the woman is already overweight, you know, overweight and obese, then your risk of getting gestational diabetes is high. If you've had a previous history of gestational diabetes yourself, so for instance, in a previous pregnancy, you develop diabetes, which went away after the baby was born. When you get pregnant again, there's a higher risk of developing the diabetes again during that pregnancy, you know. Or if there's a family history, if your mother developed gestational diabetes when she was pregnant with you or any of your siblings, there's a risk that you can also have the same experience as your mother. So you need to talk to your parents about their experience, because you might go through the same things that they went through, you know. So those are some of the risk factors that will make one person develop gestational diabetes when compared to another person. Right. You understand?
But is it preventable? Like I asked my mother, and my mother said, "Oh yeah, the doctor said during your pregnancy, you get me very." So, but is it preventable? So yeah.
So, I mean, that's a difficult question to answer, because even though we are saying that the risk factors tell us who is more likely to develop it, there are also women who develop gestational diabetes and they probably they don't have any of the obvious risk factors. You understand? So when it comes to gestational diabetes, it is difficult to say it's preventable, you see, because it's an interplay between your hormones and it's a lot of... So pregnancy itself is a state of confusion for the body. Yeah. You see, because you are trying to nurture a baby in there. At the same time, that baby is a parasite, in quote. So something must also prevent your body from attacking that same baby. Oh. So there's a lot going on in your body during pregnancy, and that's why there's a lot of, for instance, mood swings, all the cravings. It's all because of this confusing situation for the body, because hormones are spiking left and right, and so it will be difficult to say that if you do this, you prevent gestational diabetes. The important thing is that you need to go for regular checkups, you know, because like I said, the effects vary depending on which of the diabetes that you are experiencing in that pregnancy. So for instance, if we are starting with those who have pre-existing diabetes, for instance, the biggest risk factor is miscarriages. So typically, women who come in with recurrent miscarriages, one of the things that we need to suspect is diabetes. Does this patient or does this woman have diabetes that nobody has diagnosed yet? Is that why she's getting the recurrent miscarriages? So that is a very important thing as compared to gestational diabetes that will not necessarily cause a miscarriage in that regard.
Right. Doc, so I have a question. And, okay. All right. So, you know, when it comes to miscarriages, maybe we'll talk about this someday. When it comes to miscarriages, there are some miscarriages that are termed, I forgot the term, like it's like a fluke pregnancy. It's just there. There's nothing there.
Yes, okay, so I mean, I'm sure you're referring to the molar pregnancies.
Yeah.
Yeah,
there's nothing, it's just
yes,
nothing there.
It's just a shell, yes, it's possible.
So, would you, classify that kind of miscarriage to diabetes too?
So all miscarriages, so diabetes, pre-existing diabetes, especially if it is poorly controlled.
Right.
Can result in recurrent miscarriages. So the woman gets pregnant within 3 months, the pregnancy terminates by itself. Then she tries again, she gets pregnant within 3 months, the pregnancy will terminate. So that's a very common feature of poorly controlled diabetes.
Right.
You understand? Then, of course, there are also some women who struggle to get pregnant. So infertility can be a result of poorly controlled diabetes as well.
Too.
So now here's the thing. You struggle to get pregnant, and when you do get pregnant, then the pregnancy terminates. So that could be a sign of poorly controlled pre-existing diabetes. And we need to deal with that. Then birth defects, So poorly controlled diabetes can result in birth defects. So you get pregnant and you actually give birth to a baby.
It causes a lot of things, huh?
Yes. So that is why the prenatal screening, for instance, is very important. Once you have made up your mind that I want to get pregnant, you need to go and get yourself evaluated. Do I have everything intact? Everything is all right? Because if the diabetes is well controlled, if it's treated properly, you can get pregnant and deliver a baby and there's no problem.
Right.
So that's the challenge with pre-existing diabetes. Now, before we move on, if the baby should form properly and you go through the pregnancy process, there's something called IUGR, intrauterine growth restriction, which is also common with pre-existing diabetes. So the child is very small, and then maybe born even preterm, So that comes with its own complications as well. So pre-existing diabetes can cause all of that. On the other hand, gestational diabetes kind of causes the opposite. So the baby tends to become very, very big.
Big baby.
Very big, you see. And it's because the sugar staining, a lot of sugar is given to the baby. Because, like I said, the whole point of the sugar, the hyperglycemic state during pregnancy is so that the baby can have a lot more sugar, Now, if this is unregulated, as in the case of gestational diabetes, too much sugar goes into the baby. Now, unused sugar is converted to fat, so the baby becomes obese.
A fat baby.
Exactly. So you are going to give birth to a child who is about 4 kilos, 4.5 kilos. I've seen 5.2.
Yeah.
I mean, so for now, currently, the record in my hospital is 5.2.
I saw a 5 kilo. I was afraid.
Yes. I mean, it was a huge baby.
I've seen that.
You cannot deliver such a baby by yourself. And if you actually attempt to do that delivery by yourself, the mother will end up with injuries, down in your nether region. And the baby too will come out with injuries, fractures of the clavicle, nerve damage, etc. So such a baby has to be delivered by cesarean section.
The one I saw, the baby died.
It's a possibility.
Because she was also religious. Oh, we don't do this without, yeah. So the baby was the baby's head just stuck, but the body couldn't come out.
Exactly. So that's a catastrophic outcome. But yes, if the baby is too big, the shoulders cannot come out.
Yeah.
And if he falls the shoulders out, that is when the mother will get injuries and the baby will also get injuries as well. So if the baby goes past a certain weight, the recommendation is cesarean section. And gestational diabetes can cause that. I
love your job. I love medicine. And I like the fact that we are talking about this because there are so many people that are, religiously warped that do not want to hear any of this. But I love the fact that we are talking about this.
It's important that we understand that every decision has its consequences, and as medics, we cannot force our will on the patient. Much as we try, we cannot force our will on the patient. So at the end of the day, the patient will let us know what they want us to do, and we have no choice than to go through with what they want. Especially in our setup, where if you wanted to go and get a court order, it's
it's long.
It's long. So, but let me also chip in that when the baby, if you do deliver the baby, whether by cesarean or by natural delivery, there's a risk of death from hypoglycemia, as in low blood sugar.
Low blood sugar.
Because when the baby has been exposed to so much sugar in utero, that is inside the womb for so long, they naturally develop high insulin levels. So when you cut the cord, that insulin that was coming from the mother, that sugar that was coming from the mother is cut off. Now you have high insulin in the baby, so that high insulin will suddenly crash the sugar in the baby's blood. And so if that baby is not put on strict monitoring and possibly replaced with some IV sugar, and I use the IV sugar advisedly because there's proper, glucose that has been made for IV administration. Then you could lose that baby. And so when the baby is born, we need to pay attention to the blood glucose, but probably be monitoring every hour. Some parents get quite agitated when you are poking the baby every hour to check the sugar, but it's for a reason. You understand? We want to make sure that the blood sugar is good enough, to sustain the baby. Otherwise, we could have a catastrophic outcome.
Right. So if you're watching us right now, it's Doctor in the House, and we are talking about pregnancy and diabetes. Like the WhatsApp lines are open for you to send in your messages. So if you have any messages or any concerns that you want to ask the doctor is here to answer all those questions for you when it comes to the topic of the day, which is diabetes and pregnancy. So Doc, what about preeclampsia and high blood pressure?
So diabetes, yes. So diabetes in pregnancy actually increases your risk of getting hypertension, which then leads to preeclampsia and its older cousin, eclampsia. So eclampsia is seizure, that pregnant women get as a result of blood pressure related issues and kidney damage. So yes, preeclampsia involves a lot of processes that eventually result in problems with the kidney. So this is why actually whenever you are pregnant and you go to the hospital, they will always take urine from you. I tell my pregnant women that when you are pregnant, your body is not yours anymore, unfortunately. Every time you go to the hospital, they will draw blood, they will take urine. And because we need to check some of these things, so one of the things they check in your urine is glucose. So is there glucose in your urine? Is there protein in your urine? If there's glucose in your urine, could you be developing diabetes, or do you already have diabetes? If there's protein in your urine, could it be preeclampsia? So that's why we must check your urine every visit. Then we need to draw blood as well and check. Again, we'll check your sugar and other things. And at a particular point in pregnancy, around 14 to 20 weeks thereabout, we need to do a diabetes evaluation. Because it's not every woman who will develop the signs for you to see that this person has diabetes. So we need to check and see, does she have or does she not have? So when you come to the hospital or when you go to antenatal and they are poking you, it's for a good cause because we don't want to miss anything. But before I forget, now the risk in the baby doesn't just end with the hypoglycemia. Babies born to mothers who had gestational diabetes have a higher risk of developing type 2 diabetes themselves. So it doesn't end there. So, they have a higher risk of developing it. So they don't have it yet. They don't have it at the time they are born. But as they grow older, sometimes by early adulthood, they most likely will develop the type 2 diabetes themselves in the children born to such mothers. So without even looking like someone that can develop maybe the weight and or being obese and all that. So the point is, if I am engaging a person who has been newly diagnosed as diabetic and we are not finding any risk factor, he's not overweight, he does his regular exercises, then the next question to ask is, did your mother have diabetes during pregnancy? Because there is that connection which has been established. Doc, this is so complicated. It's so complicated. It is. But you see, the good news is that we know how to manage diabetes in pregnancy, whether it was diabetes pre-existing or diabetes that developed during pregnancy. The important thing is that you need to be consistent with your antenatal care. If you don't have any problem in your pregnancy, you don't go to the hospital. I mean, you don't do antenatal as frequently. I think once every trimester, and then you do a final one. So only about 4 or 5 times. If you have such an issue in pregnancy, you'll be required to go a bit more frequently. So you need to engage with your healthcare provider so that you don't assume that they are trying to just waste your time, or you don't just say, my friend is going only 4 times. Why am I going plenty? Let me also sit in the house. You see, your case is unique. Right. So when someone is diagnosed of the gestational diabetes,
Is there something that the person can do, or let's say, how important is nutrition,
Very
exercising,
important.
and so on when it comes
So
to
the management is similar to managing diabetes. So diet is important, especially in our setting, when people are pregnant, they are told not to eat certain foods, and then things like ayelo and chalk become a mainstay. All those ones we don't advise you to engage to eat any of those things because it does not help you.
Right.
But diet, good diet, balanced diet, adequate carbohydrates, protein very important. Some pregnant women are told not to eat protein. They don't eat snail, they don't eat eggs. Eggs and snails are actually good sources of protein, so please eat them. Good fats, not what's it called?
the trans fat.
Trans fats, and you get trans fat from reusing oils, for instance.
And processed food.
And processed food, cut down on processed foods. The exercise is very good for pregnant women. In our local setting, we actually discourage pregnant women from exercising, but no, exercise is very, very good, provided they are not overdoing it. So exercise within your limits. If it's a walk you want to take, you can go ahead and walk. If it's a jog you're allowed to jog, so long as there's no contraindication, you have not had any bleeding or low abdominal pain, you can actually jog. There are women who have actually jogged all the way into the labor ward, so there's no problem with exercising during pregnancy. Very, very important. So, and then your medication, once you are diagnosed as diabetic, you will be started on medication.
Right.
These medications are safe in pregnancy, so you have to take them to help regulate your blood sugar. Because if you don't do that, then the baby is going to continue getting bigger and bigger until you cannot deliver by yourself. So we want to, manage it as much as possible.
Right. So we have a question here, Doc. It says, does having a child at 30, 31 affect anything? The mother of the baby?
Not that. I mean, 30 is actually a good age to have your baby. But when you go above 35 and you enter into 40s, especially for a first baby, then you're entering into should I say chaotic areas of life. But even with that, we know how to manage it. You just have to be consistent with your hospital attendance.
All right. So what precautions should people actually take during labor? I mean, that's somebody with gestational diabetes.
Well, I mean, the first thing is you need to go for antenatal.
Very important.
Once you're going for antenatal, we'll identify the risk factors and we'll manage those risk factors. And then so that we'll know, are you actually a candidate for SVD to deliver yourself, or are you a candidate for cesarean? So once we know which is which, then you are counseled so that sometimes you tell a woman that this pregnancy has to be cesarean. Then the woman will tell you that I've delivered all my babies by myself, so this one to deliver myself.
I'm a Hebrew woman. I will deliver like a Hebrew woman.
And they'll always find somebody to help them push. And then especially if you're in the teaching hospital, then you'll be there, and then they rush this person in with the baby's
head.
And now we don't know what to do. So you see, the painful thing is to actually go through the labor and still end up on the table for a cesarean. So if you are counseled for cesarean, looking at all the factors available, please, you listen to your doctor. You can always get a second opinion, and do that way before the labor sets in. Don't wait until the labor sets in and then you decide, you are now deciding what to do.
Right.
So follow your antenatal schedule, and we'll definitely pick up some of these things.
All right, so Doc, the baby is out now, right? And of course, this person has gestational diabetes during pregnancy. So the baby is out now. At what point should she now retest to see if this thing is gone? So
when a woman delivers, we as medics, we still consider her pregnant for 6 weeks.
Pregnancy when?
6 weeks after delivery. Oh. Because it takes 6 weeks for all the hormones and all those things to return to normal. So that is why your final review is at 6 weeks, and that is when we'll confirm whether the diabetes has resolved or is still there. So if the diabetes persists after 6 weeks, or let me put it this way, if 6 weeks post-delivery, your blood sugar is still high, then it means that it was not gestational diabetes in the first place. It was a pre-existing diabetes that was only discovered during pregnancy. So then it means that you have type 2 diabetes. Right. But if we are testing at the 6 weeks and the diabetes or the sugar is normal without medication, then it means that it was gestational diabetes. So now you go home, and then if you do get pregnant again, we will check again and see if it has returned in quotes.
Right. So we actually have a message here. Good morning, doctor. Please, I want to ask if there's a particular food in pregnancy that can trigger gestational diabetes.
No. So diabetes in general is not necessarily about the food you are eating.
Because that's what they tell us.
No.
Stop eating sugar. Stop. You will get diabetes.
So it's not direct. It's not directly related to the food you are eating.
Wow.
It's about how your body now handles the byproduct of the food, which is the sugar. So when the sugar now enters your blood, insulin is supposed to push it into the areas where to be used, which is in the muscles. Right. But then unfortunately, the insulin is challenged, so then now your sugar begins to go up. So there's no particular food that you eat that will necessarily trigger diabetes.
Right.
Having said that, the more processed the food is, the faster your sugar level will rise. So that's a little caveat you have to be aware of. So for instance, if you took orange fruit and then you squeeze the juice and you drank it, versus taking orange juice in a box.
In the pack,
The one in the box will shoot up your blood sugar faster than the fruit juice. I mean, than the juice from the fruit itself.
Organic food, though. So, doctor, we have another message. I know it's not about diabetes, but she's pregnant. Hello, doctor. I'm pregnant and I was told I have a cyst at my right side. Can it harm my baby?
At the right side, so I'm assuming this is an ovarian cyst.
Yes.
So it depends on how old the pregnancy is, because when you have your period, you always have a cyst. When the egg is released, there's a cyst that forms. It's called the corpus luteum. Should you become pregnant, that corpus luteal cyst is what sustains the pregnancy until the placenta forms. So if it's an early pregnancy before the placenta has formed, typically the placenta forms around 13 weeks, 12 weeks, 13, 14 weeks, thereabouts. So if the pregnancy is before that, it's that young, then the cyst being there is normal. So it depends on how old the pregnancy is.
Yeah. All right. Thank you so much, doctor. It has been a very interesting conversation. But then again, what advice would you give women? And then after that, you can share us the tip of the week.
I think, pregnancy is a normal part of human life, So in as much as there are a lot of challenges that come as a result of pregnancy, we know how to manage or how to deal with a lot of these challenges. So the important thing is that go through a prenatal screening if you have the chance, and then if there's anything that is picked up at that point, we can deal with it so that when you do get pregnant, we can manage you throughout the pregnancy and be sure that you're going to have a good outcome of that pregnancy.
Right. Okay, your tip of the week?
Yes, so diabetes in pregnancy does not only affect the mother. The effects on the child may develop even in adulthood. So that's the point I was making. So it doesn't end when the baby is born. That baby could also develop type 2 diabetes in later life because the mother had gestational diabetes.
Thank you, doctor. It was really nice having this conversation. Ladies and gentlemen, the doctor in the house was Dr. Kelvin Owusu, who's a wellness consultant at Violet's Medical Center. Where is Violet's Medical Center?
Violet is in Kwabenya, Musuku roundabout.
How can people reach out?
Well, we are active on social media. You can find us at Violet's Medical on all social media channels. You can also find me as well, Kelvin Owusu, MD, on all social media channels.
All right. Thank you so much. Ladies and gentlemen, this has been Doctor in the House. My name is Chris Kata.